Dr. V with infectious disease, thank you for joining us.
Hi, I'm Dr. Horn. Thank you for being here. We're going to discuss urinary tract infections today. And I think this is a great topic. We have a lot to talk about. These are frequent questions that we get. And so, I think it's great to talk about this and kind of get everybody on the same page and a good kind of foundation of, because this is kind of a tricky topic. I think urinary tract infections in general are not very straightforward and not very clear a lot of the times.
We have some updated information from IDSA and urology guidelines too, and we'll make sure to record it and send you all the slides afterwards as well. All right, so let's get started. So urinary tract infection. So it costs us a lot of money when we have urinary tract infection, close to $2 billion in United States. And 60% of the women who will experience asymptomatic acute symptomatic bacterial cystitis, and 20 to 40% of these are likely to happen for the first time. Oh, other episodes. So Dr. Horn.
Yeah, and so, this is all highlighting the importance of urinary tract infections because they're so common, and cystitis, bladder infection, lower UTI, pyelonephritis is a renal infection, upper urinary tract infection, and urinary tract symptoms occur in 20% of women each year, and millions of visits. And so these are the kind of things that people see every day. And it's especially when it comes to antimicrobial stewardship, it's especially important to the things that you see commonly to kind of realize what needs antibiotics and what doesn't, because it's such a high volume of antibiotics that are used for things like this that are very common and oftentimes unclear. So it's the things that we don't have great tests for, and it's kind of hard to determine whether antibiotics are used. And the easiest thing to do is just to give everybody antibiotics, and that's why it's good to discuss.
Yeah, and today our goal is to discuss how not to give antibiotics because we give way too many.
Yeah.
And it's interesting though, just to make sure that we look at most of the time the urinary tract infection visits to primary care doctors, any type of visits, are 84% in females. So it happens predominantly in females. So that's important to know, and we'll talk about why in a little bit.
And as far as asymptomatic bacteriuria, this is a great topic that goes hand in hand with urinary tract infections, because asymptomatic bacteriuria is when people have bacteria in the urine, but they don't have any symptoms. They're asymptomatic. And so, and that's normal. It's normal and common. So a lot of times people think that there shouldn't be any bacteria in the urine, but people can have normal flora there. Just as your gut has normal flora, they can have bacteria in their bladder. Normally, that's actually a good thing, and it's kind of seen as preventing
bad
bacteria from seeding, right?
Yeah.
So I think I think of it the same way as your gut, and having I kind of think about it as like a forest, and if you throw a seed in a forest, if there are no trees around or anything, there are a lot of nutrients that can start growing. But if there are other trees and there's other bushes and things, then they all have to compete for nutrients, and the seed won't grow in a very forested place as well. And that's kind of how I think about it. So if there's already a lot of good bacteria and there's bad bacteria that lands there, it's less likely to cause a problem, less likely to start growing if there's already a lot of good bacteria. And so if you have a patient with bacteria in the urine, but they have no symptoms, then they don't need to be treated. And that's the first question that we ask.
Yeah, and also another really good point to see here is as we get older, we have more bacteria in our bladder. So, the anatomy kind of gets relaxed. So, a lot of bacteria in our genital area is able to go up the bladder. So as you see here, if you're 70 to 90-year-old female, the chances of you having asymptomatic bacteria is about 11 to 15%. As you get long-term care female, it's 25 to 50%. In males also, as we get older, 15 to 50%. So the big takeaway is when we get older, the anatomy changes and more bacteria is able to get into the bladder. But that doesn't mean it's a bad thing. And we need to make sure we're not treating this over and over again. This is when we get into trouble with, long-term care patients, elderly patients. They come into the ER clinic, they have other symptoms. We check a urine, it has bacteria, they get antibiotics over and over again.
Mm-hmm.
Now they have ESBL, now they get C. diff. So we really have to start like understanding and stopping that cycle.
Right, that's exactly how I feel. And my example is usually there's a 92-year-old woman that comes in and says she feels tired. And then they'll check a urine and they'll say, oh, you have a urinary tract infection. And the 92-year-old woman will say, really, I don't have any dysuria, I don't have any frequency, I don't, and then I didn't know I had a urinary tract infection. And those are the patients that, I would call it asymptomatic bacteria, and they don't need treatment. And that can, conserve antibiotics.
And another thing is, if they don't have symptoms, don't get urine culture.
Right.
There's no need to.
Right. Yeah. Then I would say don't get your urine. Don't check the urine unless you have symptoms in the future.
Yeah.
And this last one here. Sorry. This last one is long-term indwelling urinary catheters. That's going to be greater than 90. Oftentimes, 100% of the time they're going to grow something. And then the question is, do they need treatment?
Yeah. And I like that you pointed that out. When you have a Foley catheter in your urethra, the catheter itself gets colonized with bacteria and it causes biofilm. Just like the biofilm we see in the pipes and things like that, bacteria causes that yucky material. So within 1 day of having Foley catheter, you have 10% of colonization. So if somebody has a Foley catheter for like 10 days, it's over 90%. So Foley catheter, if you get urine out, it's always going to have bacteria. So it's really important to know that. So next slide.
So asymptomatic bacteriuria. So that's bacteria in the urine and having no symptoms. So bacteria in the urine from a person without symptoms of a urinary tract infection. And remember, foul smelling or cloudy urine does not indicate a urinary tract infection. So, when people check a UA, they check a urinalysis on a patient, some people have, you can set it up to reflex to culture. And that's an order a lot of places where you say urinalysis reflex to culture. And what that means is if they'll have criteria, and if it meets some of the criteria, then they'll do a culture if there's a concern for an infection. And Dr. V here actually had changed some of those criteria and saved the system a lot of money.
So when I started in one of our system, we had so many criteria to do urine culture. And what we looked at literature and we changed it to only white cells. So white cells more than 10 can reflex to culture if they have symptoms. We took away everything else. And it's really important because when we are rounding and stuff, sometimes our nursing staff or residents, they'll tell us, oh, the urine looks really cloudy, or the urine is smelly. That doesn't mean it's a urinary tract infection. So we really have to be careful not to call it a UTI.
Yeah, I would hate to be the person in the lab that smells it and says it smells funny.
Yeah.
Like, I don't know whose urine smells good. Right. So, but here it says foul smelling or cloudy urine. So as far as criteria, so if your hospital system has criteria for that reflexes to culture, you can remove this as criteria, and it prevents a lot of antibiotics being given out that don't need to be given. And then mental status changes alone do not indicate a urinary tract infection. This is one thing it's very common for people to say is their mental status, goes up and down. And sometimes we'll have patients come into the hospital and then they won't get any antibiotics and their mental status, they came in with mental status changes and then they improve without antibiotics. And then I think that goes to support that they didn't need antibiotics if they're improving even without it.
Yeah, and the recent asymptomatic bacteriuria guidelines from 2019 tells us that when you have elderly patients with mental status change, don't just assume it's UTI. The majority of the times it's dehydration is the cause. So they want you to look at other, do they have pneumonia? Are they dehydrated? And then get a urine culture if they're not getting better in the next couple of days. So it's really important not to use mental status in the elderly as a UTI indication.
And then the last one here is pyuria. So that's like white cells. So if you have a high number of white cells in the urine, it can be seen in patients with a urinary tract infection. It's one of the most sensitive things to say it's a urinary tract infection, but it's not diagnostic. And so just if someone comes in and if they don't have any symptoms, but they have some white cells in their urine, I still wouldn't call that a urinary tract infection.
Agreed.
And it's kind of, so the most important thing are symptoms. So pyorrhea is common in patients with asymptomatic bacteriuria or asymptomatic pyorrhea. So here they have patients with asymptomatic bacteriuria, and then do they have white cells in the urine or not? And so here, it's showing young women versus pregnant women, and it's essentially showing that pyorrhea is common. So WBCs in the urine is something that's common, and it's not really that helpful.
Yeah. It's helpful if they have symptoms. If they don't have symptoms and you just find white cells, it doesn't mean anything. So we should really stop chasing the white cells by itself too. Yeah,
and this is what makes urinary tract infections difficult and tricky, is because there's no one thing that you would look at. Well, if there were one thing, it would be symptoms, but even symptoms alone, you have to look at the big picture and everything. And, do they have symptoms? Are they consistent with a urinary tract infection? Do they have bacteria? So it kind of, you have to take it all as a whole.
So I want to point this, I really like this graph from the guidelines, asymptomatic bacteria guidelines, where if you all look here, it shows no difference because it's either favors antibiotic should be on this side. So basically they looked at if you have asymptomatic bacteriuria and you had prosthetic joint, right? Do you have to give antibiotic? Can you prevent prostate knee joint infection, shoulder joint infection if there's hardware? Basically, there's no benefit. Studies are inconclusive. It doesn't, if you treat the urine, it's not going to help prevent knee infection. So it's really important. Now there's data to talk when we have surgeons and things like that, when they want to do surgery, you do not need to treat the urine to prevent knee infection, shoulder infection, hip infection.
Yeah, so if a patient's going to have any kind of surgery, sometimes the surgeon will get a urine culture and then say, oh, if they have a prosthetic knee or hip or anything, even though we're doing this other surgery, they're having a gallbladder surgery, they'll want to give them antibiotics sometimes because they are concerned that the bacteria in the urine is going to go to the prosthetic joint and cause an infection. But that's really not the case. So the bacteria in the urine will stay in the urine and not get into the blood and infect a joint.
So we don't have to chase the bacteria in the urine. You just have to give pre-op antibiotic. Like if you're doing a chest surgery or knee surgery, just give the appropriate pre-op.
Just the usual pre-op. Yep, exactly. Yeah. Now, asymptomatic bacteria. So when do you treat asymptomatic bacteria? So it's not indicated for chronic indwelling urinary catheters. It's indicated for 3 reasons: for pregnancy, and we'll talk about this more in just a bit on another slide. The reason you treat in pregnancy is to prevent preterm labor, and they have an increased risk of getting pyelonephritis, of the bacteria going up into the kidneys. So pregnancy is important to treat. Renal transplant within a month after transplant. And then pre-op urological procedures. So if they're going to have, if they have bacteria in the urine and they're going to have a urological procedure, there's a risk of that bacteria getting pushed into the blood. And so when you give antibiotics for a urologic procedure, you're not trying to sterilize the bladder. You're just trying to keep it from going from the bladder to the blood.
So, for the renal transplant, it used to be give it for 6 months. Recent guidelines say it's only 1 month after transplant you need to give antibiotics, not after 1 month. So that's a recent change as well. And then here you could see when you screen for asymptomatic bacteria in pregnancy, like Dr. Horn was saying, especially when you have that asymptomatic bacteria when you're 12 to 16 weeks of gestation, It's try to help prevent pyelonephritis, preterm labor, low infant birth. So all these things are related to pregnancy and asymptomatic bacteria. So this is really, in this case, you could screen. And then, like you were saying, impending urological, like cystoscopy, lithotripsy, going and taking the stones out. In those cases, you could give antibiotic 30 to 60 minutes before the procedure. You don't need to give it 5 days before the procedure, 10-day course, just 30 to 60 minutes before you go do the procedure.
Yeah, and I think of this as, I was talking before about a 92-year-old female with fatigue, and this I think of a 52-year-old previous smoker that's going to have a cystoscopy. And we see this where they'll get antibiotics for a while, and then they'll recheck the urine, and it'll be there again, and then they'll recheck again, and they'll keep treating and rechecking. And they get a lot of antibiotics sometimes when really they just need a one-time before the procedure to prevent the bacteria from going into the blood. And the urologist will talk about when they do a cystoscopy, they kind of inflate everything so they can see with a camera, and they'll talk about they're concerned about that high pressure of pushing things into the blood.
So just like any other pre-op,
right,
just if you have asymptomatic bacteria, target that bacteria. Make sure you all give antibiotic prior to the procedure. And again, if you have renal transplant, treat asymptomatic bacteria 1 month after transplant.
Yeah, and that 92-year-old, I think of this as the 52-year-old, where they come in and they say, you have a urinary tract infection. And he does the same thing that the 92-year-old said. He says, really? I don't have dysuria, I don't have frequency, I don't have urgency. And so it's good to understand asymptomatic bacteria.
And so randomized controlled trials have demonstrated lack of benefit when you give treatment for asymptomatic bacteriuria. So they have looked in other population, like if you have asymptomatic bacteria, is giving antibiotics going to make you feel any better? So healthy, non-pregnant females, patients with diabetes, long-term catheter, elderly females in long-term care facilities, renal transplant for the first month, and patient undergoing like orthopedic surgery, like we talked about. It's not benefit to do that.
Right, and not only is it not beneficial, it actually can cause harm, right? So, so yeah, antibiotics aren't harmful, and I think we see that especially because we see the downsides of giving antibiotics with C. diff and multi-drug resistant organisms, and it's really I feel bad when a patient comes in with C. diff when they were treated for asymptomatic bacteria, when they really didn't need antibiotics in the first place, and they come in with C. diff or a multi-drug resistant organism. Some of the patients get treated over and over and over again, and they develop a lot of resistance, and then they consult us, and then we'll call the patient and say, do you have any symptoms at all? And they'll say, no, I don't have any symptoms, and then so we'll recommend not giving treatment. So urinary tracts in women, and then classification of dysuria. So there's cystitis, which is bladder only, cystitis with subclinical pyelonephritis, so a kidney infection, STDs, vaginitis, interstitial cystitis, and other poorly understood causes. So yeah, there are other causes of dysuria. So it's important to kind of see what is causing the dysuria in this patient. And not all dysuria is urinary tract infection.
Yeah, we'll talk a little bit about especially women when they hit menopause. So pain on urination, it doesn't always mean it's infection. So next slide here. So for you, especially for females, just like we highlighted earlier, 84% of females are the ones that visit for UTI symptoms, right? So the colon flora, which has our colon is great, our stool has lots of good bacteria, but they can come out and they can colonize the vaginal flora, and then they can actually go into the bladder. So that's what usually happens. And sometimes the external bacteria gets into the bladder. Again, that doesn't mean infection. It can be asymptomatic bacteriuria. but it's much easier for females to get this at a younger age compared to males getting colonized a little bit lower, but it happens as they get older. And kind of can show, usually, you know, when patients present, I would say the big things that I see is urgency, needing to pee every 5 minutes, frequency, needing to go every 5 minutes, and pain. What do you usually see?
Yeah, I think, and urgency, frequency, dysuria, those are the big ones. I think, you know, fever, oftentimes with urinary tract infection, fever isn't a big one. Usually if they say fever, I start wondering about pyelonephritis.
Yes, that's a really good point. Fever means you start thinking, is the infection going up the urethra into the kidneys? So now we have a different type of process. So clinical, how do you tell the difference, right? When a cystitis, a bladder infection, versus vaginitis, external vaginal infection irritation. So clinical clues for vaginitis, external infection, is pain externally rather than internally. So they're not going to have suprapubic tenderness and things like that. Sometimes you'll have discharge, which can be due to yeast infection, trichomonas, different types of like external infection. And usually when you have external infection, you're not going to get you can have white cells, but low likely to have white cells in the urine. And external infection causes pain with intercourse, but it doesn't cause you to have urgency or frequency, because again, it's externally in the vaginal area, not internally. So when do we think about complication? I would say pregnancy is one of the big ones.
Mm-hmm. Yeah, and pregnancy, it's really important to treat. To make sure it's treated and actually check again to make sure that nothing is there for the reasons we discussed before. And hospital acquired, catheter, calculi. If they have stones, it's very hard to get rid of because the stones are porous and the bacteria can get into the pores and keep reoccurring. Diabetes, it's really important to have their diabetes controlled and properly treated. Otherwise, it's hard to get urinary tract infections under control. And structural or functional abnormalities and post-renal transplant. I think of things are complicated. I generally think of it as if it's a patient that comes in and they don't really have too many comorbidities, and it's a straightforward urinary tract infection without anything else going on. Otherwise, I have a pretty low threshold to call it complicated.
Yep. And just for quick, especially outpatient ER settings, like we talked about, tenderness, suprapubic, it's kind of sensitive. It's not very insensitive about 10% of the cases, but very specific. When you do UA dipstick, again, it might be, if you look at white cells, Lucas rate, it might be helpful if you have symptoms. If you don't have symptoms and you just find white cells, it's not very helpful. And white cells in the urine, again, like we talked about, it's helpful if you have symptoms. So just always coming back to what is the patient presenting with. And the most common bacteria, if it's uncomplicated or complicated, is usually E. coli. E. coli is one of the most common. And, then you get other gram-negative bacteria like Klebsiella, Proteus, things that we find in the gut flora also shows up in the urine. So a lot of times gram negatives and then sometimes gram positives.
Yeah, and so what this means is that if someone's coming in with a urinary tract infection, you want to, whatever you give to treat, you want to make sure that you're covering E. coli. If you don't have a culture results back yet, you want to make sure that the E. coli that you're treating, you're giving an antibiotic that on your antibiogram, if you have an antibiogram, that the antibiotic it would work for the E. coli in your area.
Yeah, that's really, we'll talk a little bit about antibiograms too. And, if it's a complicated patient that gets admitted to the hospital and you need to know more, especially pyelonephritis, fevers, chills, they're in the hospital, then consider getting an ultrasound of the kidney or a CT of the kidney. especially in children, we don't take care of children, but, pediatricians do that a lot. But also, we want to make sure if it's a complicated infection, getting imaging kind of helps rule out, do they have a stone? Is there enlarged prostate? Is there an abscess in the kidney or bladder? So it's really, and if they're immunosuppressed, you can't really tell. So all those reasons, it's really good if they have sepsis to get a picture of the bladder and kidneys to make sure we're not missing bad things like cancer, abscess, pyelo, and things like that.
Yeah, and I had a patient just last month. We were treating for pyelo, and we got a CT, and it showed that they had an abscess there. And when there's an abscess, one of the common questions we get with abscesses, wherever they are, the question is duration of therapy. And really, I think the most important thing with duration with abscesses, it's not only the size of the abscess, but getting follow-up imaging to ensure resolution, because you want to make sure that it goes away completely. And really, it's just to guess duration unless you see that it's gone. And that's what I would prefer is to treat for, and it depends on the size of the abscess, but treat for a few weeks and then re-image and make sure that it's completely resolved, because sometimes those abscesses need drainage. And if they're like this patient we saw last month, it wasn't large enough for interventional radiology to drain it. So just re-imaging and making sure that it goes away.
And that's really important what you just said, because kidney abscesses can be really bad.
Yeah.
That sometimes you have to take out the kidney.
Yeah.
It's really important to re-image and then drainage if possible, and keep a very, very close eye. Some of these patients, it depends on exactly when the abscess goes away. Sometimes it might be 3 weeks, 4 weeks, 6 weeks. It all depends on how the abscess is resolving.
Right, and ideally you would have bacteria in the urine from your urine culture to identify, what is that abscess there. And if you don't have that, then it's also challenging because you're not sure if the antibiotic you're giving is the right antibiotic for that abscess. And while you also have kidney abscesses, the other thing with anatomic studies would be in men, they can have prostate abscesses. And so, if we get imaging, sometimes we'll find a prostate abscess, if we're expecting it or not expecting it. But for those, recurrent infections or getting treated and then coming in with a recurrent infection would be something for sure that you'd want to get imaging for.
Yeah. And then again, you don't need culture for clearance except in pregnancies, and test for recurrent or persistent symptoms. If they have bad symptoms, then you can retest them if needed. So now we're going to talk about recurrent UTI. We get this a lot as well. So what is recurrent UTI? 2 infections within 6 months, or 3 infections in 1 year. Usually more simple than complicated infection, reinfection more than relapse. So relapse, not getting better and coming back right away. So usually it's reinfection again. So that's kind of recurrent infection, 2 or more or 3 or more in a year. So this is kind of how to follow a recurrent infection. It's for, in that yellow box in there, it talks about it's for normal immunocompetent patients. So not for if you have any anatomical issues or immunosuppressor drug-resistant bacteria. So if you have recurrent infection, you talk to the physician, you get cultures, and then you see, and you evaluate the patient. Is it complicated? If it's complicated, you need more evaluations like imaging, urology. But it's non-complicated, then you have to have a good decision-making with yourself and the patient and talk about antibiotics. How do you want to do this? So sometimes you could do self-directed antibiotics. If the patient knows they're getting recurrent infection, and you could say, hey, when you get the symptoms, here's Bactrim, take it for 3 days, right? If it doesn't get better, let me know, we could try something different. Another way to do it also, this young female, she gets UTI right after intercourse, you could say, hey, if this keeps on happening, I'm going to give you Bactrim or nitrofurantoin, And you could take it post-coitally, one time to make sure you prevent UTIs. Or you could get culture and treat the patient. So those are some strategies that you could use. Prophylaxis, we get asked this a lot. And you can do continuous prophylaxis with a low-dose antibiotic, but when you do prophylaxis, you create resistance. So I personally don't like to do a lot of prophylaxis. Generally, don't do it for more than 12 months. Please don't give nitrofurantoin to an elderly patient over the age of 65. It's not, you shouldn't give microbit to over 65. It can cause pulmonary fibrosis. Yep. So have to be really careful. So what I prefer is treating as needed. And then, of course, non-antibiotic therapy like cranberry juice, behavioral changes. But I'm going to touch a little bit about post-menopausal females and what do we do when there's changes in the vaginal area. How can we use estrogen therapy? So I think that's a really important thing to know too. So quick picture here, our rectal area, we have lots of bacteria. It's part of our stool. And here is a vaginal area and bladder area, urethra. So the bacteria, it's so easy for it to just come into this region. And then it's so easy for the bacteria to go up into the bladder and just hang out, right? So this is what happens, but as we get older, this area kind of becomes lax. So more bacteria can travel into different parts, especially into our bladder. Just like we talked about before, it's just colonization. Most of the time, if they don't have symptoms, don't treat it. But when you do have menopause, the new term is genital urinary syndrome of menopause, not atrophy, not vaginal atrophy. And what happens is, it's really important to know that when females are in the menopausal age, the good bacteria, lactobacillus, that we have in our vaginal flora, it starts changing because of the external vaginal area. And and because of that, now some of the good bacteria go away, and now Enterobacteriaceae, E. coli, and things start colonizing. So as we get older in females, when you have menopause, vaginal pH increases, good bacteria goes down, and bad bacteria colonization goes up a little bit. So it's important to know. So what do we do when females have external pain, during their menopause? You could do topical estrogen cream, estradiol 0.01, 1 gram 3 times a week with tip of the finger. You could apply it 3 times a week. It doesn't increase breast cancer risk. It doesn't increase DVT or PEs for using externally in the vaginal area. So this is important to know, and it really can help the females in the menopausal time. Please let me know if you have any questions or concern, but we just wanted to make sure we talked about this as well.
And then the differential diagnosis, as far as recurrent infections. So when you're thinking about someone that gets recurrent infections, recurrent urinary tract infections, interstitial cystitis, painful bladder syndrome, PID, vaginitis, urethritis, malignancy, neurogenic bladder dysfunction, there are kind of a number of things when you think of recurrent infections. And so it's important to think of, what could be causing this recurrent infection. And recurrent infection is when they get better, and then at some point, whether it's weeks, months, they have it again. And so nephrolithiasis, I would say, is one of the big ones in patients that have stones with essentially bacteria all over the stones, which is really hard to treat unless you look at the underlying reason and fix that underlying reason.
So remove the stones would be helpful. And then the other thing that we get asked all the time is neurogenic bladder. So what happens? So bladder get over distended when the nerves in the bladder don't work well. And the contraction, it leads to some of the cell death. So you have tearing of the mucosa in the bladder, and a lot more bacteria goes in there. And the urine just stays in the bladder. It doesn't come out as much. So you have stagnant urine, which becomes a good area for bacteria to colonize. But that does not mean you need to treat it. If they don't have symptoms, like we talked about earlier, in neurogenic bladder patients, no symptoms, avoid treatment, don't check urine culture, because you expectedly, you will have bacteria in the urine. Oh, I like this.
So yeah, myths and concepts. So people, you may have heard people say that urine is sterile. So people say urine is sterile, it's not supposed to have any bacteria in it. And that's actually not true. So as we were discussing, it's okay to have bacteria in the urine as asymptomatic bacteriuria. And when people have asymptomatic bacteriuria, they'll do these studies and they'll say, does it help to treat that and to sterilize the urine? And it doesn't help, and it's actually harmful, because if you get rid of that bacteria that's normally there, it can make them increase their risk for getting a urinary tract infection right after treating them. So they'll get antibiotics, and they're actually increased risk for getting a urinary tract infection after they get treated. So,
and one of the big things that we put it, dirty urine, we hear this a lot, the urine is dirty.
Yeah, but do they have symptoms, right?
Yeah, urine is never dirty. It's part of your, so I just think, like Dr. Horn was saying, do they have symptoms? Pre and post-coital voiding, studies have shown it doesn't really help. Good hygiene practices, tampons, probiotic doesn't really help. Test of cure, except for pregnancy, doesn't really help.
And that's, the test of cure, they'll treat and then they'll test again and it will grow again and then they'll treat again. And it's just this cycle of
yes.
Keep treating, and even if they don't have any symptoms, which isn't a good plan.
And delirium in elderly with abnormal UA, you find white cells, you find bacteria, is not UTI, does not equal UTI. So these are good pearls to remember. And just quick thing about upper infection. With this, you get fevers, chills, sometimes bacteria in the blood, lower back pain, more severe symptoms. With pyelonephritis, there's mild and moderate. Make sure we rule out abscesses and things like that with imaging. And important thing to know is, what do you treat, right? When somebody gets admitted with pyelonephritis in the hospital, if it's most of the time gram-negative, so think about like the third generation cephalosporin. Gram-positive, we don't see it as much. It can happen, I suppose. Yeah. So you have vancomycin. And then know your antibiogram in your area. So I usually don't, if somebody's here for urosepsis or admitted to the hospital with bad pyelo, my first go-to is never Bactrim, never fluoroquinolone. What would you say to that?
Oh, if they're in the hospital, I like ceftriaxone. Yeah. Yes. And if you look at your antibiogram, if you're able to look at the susceptibilities in your area, generally ceftriaxone is very good, right? So here, this is an example of an antibiogram. So they'll, in the microbiology lab, they'll get samples, like here's E. coli, and then they'll test and see which antibiotics work. And here you have a lot of isolates, 9,605 isolates. So that's a lot. And then they'll say, what's the likelihood that an antibiotic will work? And if we follow it along, here we have levofloxacin for E. coli.
78%, not very good.
Yeah, so 78% of the time levofloxacin will work. And generally, if it's 90% or better, that's when we say that it's consider using that. But this would actually mean there's a lot of resistance to levofloxacin for E. coli in this area. So,
and if you look at Bactrim too, if you walk, it's 73%. So that's why when somebody is sick enough to get admitted to the hospital, and if you look at ceftriaxone, for example, in here,
ceftriaxone, 91%.
No,
is it? Where's ceftriaxone?
94%. Ceftriaxone is right here.
It's like an eye test for me.
So it's 94%. So
that's good.
Yeah. So it's okay to give Bactrim in the outpatient setting if you need to, but if somebody is sick in the hospital, these two drugs should not be. It's like third
Right,
generation
and
cephalosporin.
if they've been getting levofloxacin in the outpatient setting, when they get inpatient, you don't want to continue that antibiotic
Yes.
because it's not working. And unless they've been vomiting and they haven't been able to keep it down. But even then, if they're sick enough to be in the hospital, I would consider giving something like ceftriaxone.
So always your antibiogram is a nice cheat
Yep.
sheet to use. And quick reminder, if it's cystitis, UTI, mild, 3 days of antibiotics is great. UTI comes back again, 3 days is great. If it's pyelonephritis, data shows now 7 days is good enough. And again, usually minimum of 7 days. Sometimes you might need longer, but minimum of 7 days. And you might, complicated times, you might need imaging and neurological evaluation. So now it's lower the amount of days, better it is. So 7 days for pyelo, 7 around is enough. And one other thing to remember is prostate infection in men. So sometimes males come in with prostate infection, and that prostate is really hard to penetrate with antibiotic. What do you usually do when you get prostatic infection?
Yeah, so generally they'll say Bactrim or quinolones are the best for getting into the prostate. And anytime a man comes in with a urinary tract infection, I wonder, could this be an occult prostatitis? So could they also have prostatitis? And it's also not so obvious sometimes, if they have a prostatitis with their urinary tract infection. And the difference would be partly the antibiotic, but if you want to treat with Bactrim or quinolone, and then the duration of antibiotics, giving antibiotics for 4 to 6 weeks to really make sure that's treated appropriately. If a man with has a urinary tract infection and comes in and is treated and then has a reoccurrence very quickly, then that's when I would consider, maybe he had a prostatitis in addition, and that wasn't recognized. So it's important to make sure that you treat long enough and to make sure that you have that really taken care of.
Yeah, and sometimes we get into the trouble when you have prostatitis and the E. coli is resistant, for example, to Bactrim and quinolones. Then you don't have any other oral options. In those cases, we do IV antibiotic, unfortunately. So prostate infection, we should always remember. I also get urologists to make sure they examine the prostate, keep an eye on the prostate. So if you think about prostate infection, it's longer treatment, oral antibiotics that penetrate really well are Bactrim and quinolones.
Yeah, and sometimes we'll have patients that also have a prostate abscess. And so I think imaging is good in these patients that because they can sometimes be very difficult to treat.
So that was our last slide, and we welcome any questions, in the chat box. So if you want to unmute and ask us any questions, we're happy to answer.
Yeah, and this is a.
Yeah, go ahead. Is there a question from somebody?
Okay. Yeah, I think this can be pretty tricky because there's it's hard to sometimes get a good diagnosis, and the testing with the WBCs and looking at the symptoms and everything can sometimes be a little bit tricky. You'll have patients that are very straightforward, but then you also have kind of sometimes this gray area of, I'm not sure if this is needs treatment or not. And so I hope this was helpful. If you have any questions, please feel free to email us or call us anytime.
Well, thank you so much for joining us. We appreciate it. And we'll see you guys next month when we do the webinar.
All right. Thank you, everybody. It's good seeing everybody.